Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to you. Our topic this week, lower back pain and the non-surgical options for treating it. Our guest is pain specialist Yashar Eshraghi. Dr. Yashar Eshraghi attended medical school at Azad University in Iran. He was trained as an anesthesiology resident at the Case Western Reserve University Metro Health Medical Center. He completed a fellowship in pain medicine at the Cleveland Clinic Foundation. He is currently the medical director of pain research at Ochsner's Pain Management Division. Dr. Eshraghi is board certified in anesthesiology, chronic pain, and headache management. It's our pleasure to welcome Dr. Yashar Eshraghi to Hello Health. Good to have you with us on the program,
Thank you
Doctor.
so much. Thanks for having me, Tom.
Thank you. Well, first of all, let's start with how many people are suffering with back pain and lower back pain?
So lower back pain is actually a very common problem. So this is the most actually common complaint why people go to doctor. So about 36% of Americans get back pain every year, which is a very high number. About 60% of people over their lifetime, they get back pain. And we know the people that out of 40% that say they don't have back pain, if you look at their history, you see that 20% of them already had back pain, they just forgot about it.
What are the primary causes of back pain and lower back pain?
So good question. Back pain can have a lot of basically reasons behind it to make people suffer. And every component in the back can be the source of the pain. It can be degenerative changes in the back. So you can have some arthritis in the back. Different components of the back can have arthritis, lose their cartilage, and start being source of the pain. Any other segments like the disc can have the reason for back pain. They can herniate and push on the nerves, or they can desiccate themselves. And in the lower side, you can have the sacroiliac joint can cause of the pain, or other reasons can cause the pain too. You have a lot of disease like cancer or other sort of malignant disease that can have metastasized to the lower back area and cause pain.
And most of us are doing things in day-to-day life, right? Bending over the way we shouldn't, where we're not bending our knees, those sorts of things. It just, the back we're using it all the time. We're probably using it in ways that we shouldn't be using. We're overtaxing it. So some of it, and a lot of it, is probably just normal wear and tear, right?
That is very true. So over time, like any sort of parts, like in the car, in your house, things can get wear and tears. So like a door, if you use the oil, it starts getting noisy. Same thing, our car needs to change parts, but unfortunately we can't change parts of the body. So when we use it, if we use it too much or we don't use it correctly, over time we start getting arthritis and start getting pain. So probably it's better to be healthy, be active. There's no reason to say that if we are not active, we are going to have less pain. That's not actually true. You be more active, healthy exercises actually can prevent lower back down the road.
And we're going to show you some of those exercises at the end of our program. So what are today's treatment options for lower back pain, doctor?
So there are so many different type of treatments for lower back pain. And when patient comes to me at the office and we start talking to them that how we are going to treat your pain, I always say I'm going to make a soup for you. So in a medical term, we call it multimodal regimen. So we have a physical therapist, we have psychiatrists. We ask them to use some medications, different type of pain medications. We ask them to do some lifestyle changes, like losing weight, stop smoking cigarettes, and all these things. If they don't work, some of the complementary treatments, we can use interventions like injections and nerve blocks for them. And at the end of the road, if none of these are helpful or if they have severe symptoms, we send them to surgeon. So they might benefit from surgical intervention.
Let's start with interventional pain management. So what are the options there?
So interventions in pain management, there are some minimally invasive injections or nerve blocks that we put some medications targeted to the source of the pain to decrease and alleviate the pain and bring down the inflammation. So we basically fill the gap between medical treatment or conservative treatment and surgery. So what we are trying to do, if people who have like a pain medications, they try the physical therapy, they still have pain, or they cannot tolerate physical therapy or pain medications because of the adverse effect of that or the severity of the problem, or they got some relief, but it's not enough to put them back in normal function. So that's where we come to play, and we start using those like modalities to help them to alleviate their pain and return them to what they like to do to enjoy their lives.
Let's talk about some of these injections, some of the interventional options in more detail.
So one of the bread and butter treatments that we use, and probably most of the people to go to the pain physician, they heard about it already, is the epidural injection. So what we use, we basically put a medication in a targeted part of the pain source to bring down the inflammation. We give some local anesthetic, and which is the numbing medication, and also we use some steroid for it. Epidural injection has been around for more than 40 years. Even like one of the ones that it's on the neck area that can be a little bit more riskier than the other ones, like the first time it's been done in 1980s. And the risk is very low. Basically, 1 in 500 people actually might get some of the common problems. And the severe actually side effects can be 1 in 200,000 people can get. It's a pretty safe procedure, and it can be very rewarding for us because we can help the patients to feel better, go to physical therapy, and sometimes even get a long-term pain relief so they don't need to go through surgery go through the recovery of those kind of invasive procedures.
Are these hit and miss? So, right, you don't know, you kind of have an idea of where the pain is coming from, going in with the injection, and then sometimes you might get the relief, but then there's a question of how long is the relief going to last?
That is very true. And unfortunately, we don't have any way to know that how long this is going to last and if it's going to help or not. We know some ways to look at the people based on their symptoms, based on the chronicity of their problems and the findings on their imagings like MRIs and X-rays. So we have a way to say that, okay, you have the high likelihood to get relief out of that. And some people, we know that it's not probably going to be very successful in terms of treating their pain, but we like to try it because we want to make sure that if they are a candidate for surgery or not. Because if you can get some relief for them so they don't have to go through surgery, we like to try it. And the way it works is actually there are some bad actors, inflammatory factors, that it's called like a phospholipase A2, and they cause inflammation in the nerves and cause irritation, edema, and pain in those. So when we use steroids, what they do, they block that bad actor. So they bring down the inflammation and help irritation. We can't correct the whole pathology itself, it's the herniated disc or it's like arthritis, but what we are trying to do, that the damage is already done, the inflammation is already done, to bring it down and alleviate some of that pain.
There are different types of steroid injections. So what are the different types and how do you decide which ones to use?
So that's a very smart question because there are different types of it. Some of them, the difference between them is in terms of their potency. So some of them are short-acting, some of them are long-acting. And in terms of what part of the body, and we are injecting the joint or we are injecting the nerve root, we decide which one we use. But in terms of science, we don't really have any strong evidence to see that which steroid is better than the other one.
Yeah, because everyone would choose the long one, not the short one. But again, you don't know what's going to work until you try it.
So that's not entirely true because the long-acting one, usually it's only a few days, the long-acting. But in chronic pain, we understood that if you give the steroid, that in reality, in sort of pharmacology and standpoint, it's only a few hours, half-life. They go there, but their effect lasts a lot longer than that, sometimes a month, sometimes over a year. The reason is that when you bring the inflammation down in the nerve and it calms down, so it actually gives the patient a little bit of a treatment. It's like antibiotics you give. If somebody has an infection, you know that the antibiotic stays in the body only for a few years, but kills the germs, and the treatment probably stays forever. This is not the same, ideology, but it's sort of like works a lot longer than what you expect from like a regular steroid treatment.
Talk about joint pain in the back and the ways that joint pain is treated today.
So the joints in the back that we call them facet joints, they are true joints. They are smaller than our knee or shoulder, but they are true joints. They have some cartilage, they have some fluid in them. And over time, when we do a lot of moves that we don't want to do, we lift, we do a lot of heavy exercises, like heavy machinery work, all of those eats up our cartilage, and those joints become inflamed. So we can treat those joints with 2 different ways. We can, other than physical therapy and medications, we can inject the joint itself to bring down the inflammation like any other joint in the body, but sometimes we can go after the nerves that go to those joints. So we call them medial branch. So there are, every joint, the facet joint in the back gets 2 nerves from the same level and a level above that, and we can numb those nerves and sometimes ablate those nerves, so give long-term relief for the patients.
This is radio frequency ablation?
That is correct.
And
yes.
tell us how that would work.
So the way it works, it causes a damage to the nerve that it's a small damage. We call it Wallerian degeneration. So basically, the heat about 80 to 90 degrees with the high frequency, it moves the ions so fast and creates heat and ablates those nerves. So those nerves that are purely almost sensory nerves, so they don't really have any role in like moving our legs or doing anything that we don't want to kill those nerves. So we give the heat after very careful testing. So we use a lot of landmarks under the X-ray, and sometimes under ultrasound it can be done too. We go exactly where the nerve is supposed to be based on the anatomical and X-ray landmarks, and then we use a machine to test it. We do a sensory test to make sure that we are close to the nerve that we want to be, and we use the motor testing. We want to make sure that we are going to be away from the nerves that we don't want to ablate. And then we give a heat for a few seconds to them, puts them to sleep, but our body is smart. Those nerves grow back in the future, and they come back and bring back the nerve, and the sensation comes back. But the treatment, if exactly the same pain, it's easy. We can go after the same nerves again. We do actually testing for those. So what we do, we go give only numbing medication to those nerves beforehand. Sometimes even twice we do that. And patients go home and check their pain. And if they say, wow, this was a game changer, I got a really good relief out of that.
You know you're in the right spot.
You're in the right spot, and you bring them back and ablate those nerves.
Now, when you're ablating the nerves, I know you've done this testing on the front end. Is the patient awake? Is that important? Are you asking the patient to do anything, for example, to make sure you're hitting the right ones and not the wrong?
That is correct. So when we are doing testing, so there are different ways of doing this. Some people give small amount of sedation to the patients to make sure that they are comfortable, or we give numbing medication on the skin so they are numbed up on the where that we are going to put the needle. When we do the ablation, we still give them some sedation through their IV, but we don't want to put them completely asleep, because when we check it, actually the patient is the person that gives us the answer. So we ask them, do you feel any sensation like a tingling in your back? And they give the right answer, yes or no, to us. And the motor nerve, when you see if the pain it goes to your leg or not, they give us the yay or nay, and we know that, okay, we are in the right spot, or we have to make a little bit of a fine tuning to make sure that we're in exactly where we want to be.
All right, let's move to the sacroiliac
Iliac joint, yes.
Thank you, and the pain there. So what are the options for treating that area?
So sacroiliac joint is one of the joints that connects our sacrum to our rest of the hip. So this is a very important joint because it helps with our balance and standing, and it can get a lot of pressure with like a long-standing sitting, or any kind of like trauma, infection can cause pain in that area, or not in particular over time, like over-exercise and like sitting for a long time can cause pain in that area. One of the treatments for it is to inject steroid in that joint, inside that joint. Some people get a really long-term relief out of that. Some people don't. They get a relief, but it's too short. It's about a week or a few days. So you can't really bring those people back and keep injecting them. So we do exactly the similar thing to what we do to our back, to the facet joint. So we go after the nerves. We ablate those nerves so we can provide them long-term relief.
What's the success rate for these injections? Do they work, and for how long? I'm sure that's the first question you get from patients.
That is very true. Yeah. And there is a lot of evidence. So everything that's like, now we talk about evidence-based medicine. Everything that we believe on it, and we want to say that, okay, we want to do this procedure on patients, are based on research, extensive research. Most of them are randomized controlled trials, or very large number of patients that retrospectively have been looked at. It's very good. We have a very good evidence for epidural injections. It's a good for RFAs. We have a very good evidence behind it that helps people to feel better. And for other type of like SI joint, we have a lot of fair treatment, like evidence behind it. But for the radiofrequency ablation for SI joint currently at Ochsner, in collaboration with other centers in the country, we're doing a study to prove that it actually provides good relief for the patients.
Our guest this week is Dr. Yashar Eshraghi, and we're talking about lower back pain and the ways to treat it. In just a moment, we're going to hear from one of Dr. Eshraghi's patients, but another option for lower back pain is spinal cord stimulation. So before we hear from your patient, describe exactly what's happening.
Exactly. So spinal cord stimulation, the idea behind it, it's not new. Old Greeks used to have like a torpedo fish, and they told people that if you have a lot of headache or foot pain, you can go into the water and put torpedo fish on it, and that electricity makes you feel better. So all this idea came, and people for the gout, they used it for people who actually had gout in the past too. The idea comes from an idea we call it gait theory, which was explained with Melzek and Wall in 1965. And the way that I explain it to my patient is that if you hit your hand somewhere, what do you do first? You rub it. So when you rub it, we call it distraction, which is exactly the same thing. So there are some pain fibers that are called C fibers that go to our brain, and there are non-pain ones that A beta fibers. So when we do these, when we rub our skin, we actually, all these pain fibers that go from the same highway to our brain, we keep that highway busy with non-painful signals and don't let the pain signals go to the brain. That's exactly how...
We're tricking the brain in some respects.
You're tricking the brain, exactly. That's exactly how spinal cord stimulation works. Now we have a little better technology and we got really better at it. We think that maybe probably more into it than just blocking the pain. It does a little more than just blocking the pain. It improves other things too.
All right. This is the next step beyond torpedo fish.
That is true.
Let's listen to one of the doctor's patients.
I began to have about 10 years ago pains in my back. And I figured it was just a sign of old age and kind of lived with it with ibuprofen for a while. And my primary care physician at Oxnard suggested that I go to the pain management clinic at Oxnard Baptist. I first had to get a psychiatric evaluation that I was a good candidate for a nerve stimulator. And after I passed that, I was fitted for a week with a temporary nerve stimulator, and it worked magically. I walked out of the operating room on my own power with no pain, and it was so dramatic that I really couldn't believe it. And so a month after that, Dr. Eshraghi implanted a permanent nerve stimulator, which is really a small generator of electric current, and it's fed by a small battery, which is in my back, which you can't see or feel, and I can't feel, and you can't see. And it totally blocks all pain traveling on the nervous system to the brain. When I heard about it, I really was a little bit skeptical, and when I walked out of the operating room, I was a believer.
So obviously great relief for this patient, and still doing well?
He's still doing well. A few days ago, I actually had a chat with him, and he's really doing well, very happy with the treatment. And there's nothing more rewarding than that you see that people feel that they are back to normal life, they can do things, they can play golf, they can go about do things that they enjoyed before. It makes my day.
Absolutely. I can see the smile on your face as you're telling the story. So who's a good is there anyone who's not a good candidate for this, or who are the good candidates?
Who are good candidates? So we go actually through a very thorough and comprehensive evaluation before we select these patients for this kind of treatment.
And he mentioned the temporary one that you put in first, right?
Exactly. Yeah. That is very true. So there are different indications for it. People who have a back pain before and right after the back surgery, they still have pain, or they have a relief that after a few years the relief goes away, they develop the pain, they go to the surgeon, they look at it, and everything looks good, but there is nothing to really operate on, but they still have pain. So those are the most common type of patients that they come to us and we help them. But there are different types. People have nerve pain that in any part of the body, especially lower back area or the foot pain. Now we start kind of looking at maybe people who haven't had a surgery yet, they might benefit from this if they're not a good candidate for surgery. We use for even sometimes for vascular disease, peripheral vascular disease, or diabetic neuropathy are the ones that people get some relief out of that.
What are the components used in this spinal cord stimulation? And is the patient controlling it? Is he holding the remote?
It's a very good question, because I had similar question that one of my patients asked me, what if I lose the control? He says, like, no, you don't. If you lose the remote control, they will just give you a new one.
Right.
So actually it has different components. One component are the leads. There are specialized leads that go to the epidural space, same space that we put the epidural injection in. And there is a generator for it. So that generator is the brain. I always call this as a pacemaker for pain. Similar idea, so you have a small battery and you have some leads that go to the back to control your pain. There is a remote control that patients use it for, like they have to do some charging, or a remote control to change the programming, but it's not necessary to like move it around with yourself. The components that are actually do their job, nobody can see it, it's inside your body and it's not visible. And there's like a small, like a surgical cuts that sometimes they heal really well, so it's not really easy to recognize it.
But because the doctor brought along an image, we can see what it looks like on the inside, because you brought along an x-ray, right?
That is true.
Let's take a look at this and walk us through this, if you would.
Absolutely. Doctor. So the components for the x-ray, like when you do this, the lead, let me start with this before I show that lead. So it comes with a trial. So you asked about the trial, and that nice patient of mine talked about it. So what we do, these patients, like we show over here, patients come to the facility, and we put these specialized leads under sedation for them, and they go home to try it. I always say it's like a car that you get to test it before you buy it. So they use it, they go home, they do normal things that they do usually that cause pain, and usually about 5 to 7 days, they try it. Our technicians usually talk to them every day, make sure that if there is any change in the program needs to be done, they do it. And patients come back and we ask them how they did. If they are very happy with it and it looks like that they actually experienced quite a lot of benefit from that, and they think that it's a game changer for them, then they will come back. And this time we put the same leads, we put a small cut and put a battery or generator under their skin so they can like have it permanently to get some relief out of that. And that picture was showing you those leads in the back, and I do it in the operating room. When I do it, we check it from the back, from the side, make sure everything is in the right spot, and helps us to actually direct these leads where they are exactly supposed to be.
Very good. And finally, options for broken bones in the back. Let's talk about that.
Yes. So a lot of people, when they get older, they lose strength of their bones. We call it like osteopenia or osteoporosis. There's like a different trends of that. And when we get weaker, the traumas or the activities that usually are not that stressful on our back, it can be. So a lot of people when they are gardening, they have a small fall, they fall from stairs, they get this compressed fractures. Some of these are severe enough that need surgery, some of them are not. And when they are not severe enough to have surgery, but they can be very painful and they can affect people's lung functions, they can actually increase their mortality in the long run because they're not functional enough, then they can basically have more comorbidities. So we have a way to treat that with a minimally invasive procedure. It's called kyphoplasty and vertebroplasty to fix that fracture and improve their pain.
And how does that work?
So what we do, we go actually on the sides of the bone, under the x-ray, inside the bone, and we put some cement, medical cement in there to fix their bone, so fills the cracks. And we actually, before that, we put a balloon in there to correct the height of the compressed bone. And what it does, it fixes the bone fracture. At the same time, the heat itself, it helps with the pain. And it's a very rewarding procedure for me because a lot of these patients, right after the procedure, they have no pain. I had a patient that she actually went to have lunch the same day with her husband after the procedure.
Good for her. Well, the good news is there are some stretches and exercises you can do to help alleviate your back pain, as Molly Kimball shows us in this week's Eat Fit Minute.
So we're here at Oxnard Fitness Center in the Fit Lab, our brand new personal training studio, and we're with personal trainer George. He is going to be showing us several different lower back exercises that help to not only prevent lower back pain, but also to help treat lower back pain. And you say that everything pretty much starts with that core stabilization, that pelvic tilt.
It's very important for the client to cue them to have a brace core so we can do all the exercises that we may perform.
And the way that you explain it is if you have your hands behind your back, you're laying on the floor, almost drawing your belly button, pressing your fingers down to the floor, and that's really going to activate and engage this core.
Yes, correct.
Okay. So then once we have that stabilized core, the first main exercise you have us doing is the bridge. So with the bridge, you're raising basically your rear end off the ground a little bit as you're engaged here, and you may raise it a little or a lot. And then that next progression is to actually lift one leg while you're doing it. Next is the modified plank.
The modified plank is a great exercise to start with. We should be straight, even, engage the core, and from there we can actually progress to the next level or regress according to what we see.
And finally, here's the side plank.
The side plank is targeting the obliques, and we also want to have a correct form, the knee, hip, shoulder aligned. I have the bottom leg bent, and that is because some people have problems with their knees, so we're trying to protect that joint also.
So you can talk with your physician or physical therapist for a referral to our personal training department here at Oxnard Fitness Center. And as always, check with your physician, your physical therapist, or other healthcare professional before beginning any type of exercise program.
Our thanks to Molly, and our thanks to Dr. Yashar Eshraghi for the education and information he's provided and for his work in the Oxnard Health System. Thank you so much, Doctor. Hopefully we've offered some relief to patients and good information to get them there.
Absolutely. My pleasure.
All right. To make an appointment with any Oxnard physician, including this week's guest, or to register for any of Oxnard's Hello Health seminars, you can call Oxnard at the number you see on your screen or send us an email. And here's our address, hellohealth@oxnard.org. Love to hear from you. As a reminder, you can rewatch this week's presentation or many of our other Hello Health programs on Oxnard's website at oxnard.org. Just type Hello Health in the search box. That'll get you started. Our thanks again to this week's guests. Thanks to Humana and Oxnard for making this program possible. And our final thanks, as always, is to you for your support of this program, Hello Health. I'm Tom Bagwell, and we'll see you next time.